skin conditions that can affect women, particularly in the postmenopausal age group. As discussed before, estrogen deficiency obviously is the primary cause, causing dryness and superficial dyspareunia, pain during intercourse. Contact dermatitis, which can be allergic or irritant due to local irritation, is also very common. But there are specific skin conditions that can affect the vulval skin, particularly in the postmenopausal age group. The two common ones are Lichen sclerosus or Lichen planus. Here we'll discuss Lichen sclerosus. Lichen sclerosus is a chronic inflammatory skin condition that particularly affects the vulval skin, the skin around the anus and the genitalia in both men and women. In women, it is particularly common in the postmenopausal age group. The exact etiology is not known, but it's supposed to be an autoimmune condition. It's often prevalent with other autoimmune conditions. The distribution of Lichen sclerosus is mostly in the midline, in the vulva, in a figure of 8 distribution. This generally involves the clitoral hood, the clitoris, the labia minora, the interlabial sulcus, and the perineum and the perineal body. Typically, they do not involve the vagina and the cervix as opposed to Lichen planus. The lesions are whitish papules or plaques with ecchymosis, erosions, ulcerations, and fissures. Initially, the symptoms starts with itch. Many are, however, asymptomatic and may just be diagnosed incidentally. However, with the fissures and erosions, pain and superficial dyspareunia can be common. Scarring with passage of time is quite common, and a loss of the vulval and vaginal architecture, particularly the vulval architecture, is quite common. There is loss of labia minora and fusion at the introitus, leading to complete loss of architecture and scarring. The diagnosis is mostly clinical on inspection, and treatment is therefore empirical to start with. However, if there is any doubt about the diagnosis or the differentials, or the lesions are resistant to treatment, or there is a change in the lesions, either the symptoms or the signs, then a biopsy is indicated. With regards to treatment, a thorough understanding and explanation to the woman is essential so that she knows about the symptoms, the signs, the progression of the disease, and when in particular to seek help, to report if there is any change in the nature of the disease, the signs or the symptoms. A written documentation or specific websites is vital. Specific treatment includes ultrapotent topical corticosteroids, namely clobetasol propionate 0.05% ointments or creams every night for a week, then alternate nights for another week, and then twice weekly for I'll just delete this portion. So clobetasol propionate 0.05% cream every night for a month, then alternate nights for another month, and then twice weekly for another month, and then we should review. 60% will have complete remission of their symptoms. However, the pale shiny skin and the scarring would not go away so soon. Later on, if there is acute recurrence of the disease and the symptoms, short-term intense therapy is absolutely okay. There is evidence to suggest that long-term maintenance therapy with twice-weekly mometasone furoate 0.1% ointment can not only prevent recurrence of the disease and maintain remission, but also may prevent or delay neoplastic changes, malignant changes. In the meantime, avoiding irritants, emollient soap alternatives, moisturizers and lubricants may still be helpful. Any woman on long-term corticosteroids should have at least yearly review, either with a GP or in a specialist vulval clinic. Even asymptomatic patients may be treated so as to avoid scarring and possible malignant changes. The chance of conversion into malignancy is rare but not nil. It's roughly in the range of less than 5% for a squamous cell carcinoma. And therefore any change in the lesions, particularly erythema, ulceration or new growth, should be reported.